Welcome to Bart's Heart Centre here in London.
So he's a 63-year-old chap with inferior STEMI. He's got hypertension, high cholesterol, bradycardia, and he was transferred from North Middlesex Hospital. No allergies to statin, he says, but on the barking sheet it's not known to have anything. He's been loaded with aspirin and ticagrelor. I'll get one for you.
Yeah. Okay. Pass this round. Bit tortuous. Okay, LAO, thanks. Wire out, thanks. Flush, please.
So this is a 62-year-old gentleman. He's a smoker, hypertensive, hyperlipidemic. He's come into hospital with 8-hour history of chest pain, and his ECG shows an inferior ST elevation. He's been assessed in the ambulance. The staff have got into full PPE, and he's now been brought up into the cath lab, and we're just got access. We've got radio access in this case, and we're just getting some pictures now. What are we looking to look at first?
So we're essentially looking at the left coronary artery. We've got a Judkins left 3.5 diagnostic. There's a bit of tortuosity at the subclavian, which is resulting in a little bit of difficulty to engage in the coronary. And the plan is then to take a guide, Judkins right 4, to look at the right coronary artery.
Right. What is known about his COVID status? Do we know anything?
Yeah, so he's asymptomatic, but has not had has had no exposure, but we haven't got a COVID test back, but we have done a rapid ID and Abbott ID test, which should hopefully come back within the next 20 minutes, so we should know the status by the end of the case.
And what's our standard practice in terms of PPE, etc., for these type of cases?
Yeah, as we are all sort of demonstrating, we wear full PPE for all STEMI and people with unconfirmed COVID statuses, just for the risk of arrest and therefore aerosolizing. So we've done that for the last year and we'll continue to do so, I guess, for the foreseeable. Okay, yep. Ready for a picture? Yep. Okay. Okay, spider, please. So we're taking AR1 guide, please. Yep, picture. Okay, 1040.
So I guess we're just getting the diagnostic pictures now, and we can see that there's a disease in the circumflex. There may be something in that mid-LAD.
And then
nothing occlusive at the moment in the left system.
Okay, yep, picture. There's
probably moderate in the mid-LAD, isn't it?
Yeah, I agree. So there's 50% in the mid-LAD, but it is a bit eccentric. Might be 50 to 70, and then there's that OM, which looks significant. Be surprised if that's the culprit, though. Yeah, picture. It's tight, though.
So what's the reason for taking AR1 instead of JR4 in this case?
Yeah, I mean the tortuosity from the wrist is making things difficult, and the AR is going to give me a bit more reach and support to try and get into the right coronary, assuming it is occluded and is the culprit.
So in terms of, I guess in the COVID era, are there any other things that we'd be thinking about from an anticoagulation perspective and a heparin perspective? He's already had aspirin and ticagrelor, I presume.
Yeah, he was loaded at North Mid with aspirin and ticagrelor.
So if patients are loaded with clopidogrel, what would you do at this stage when they come in with a STEMI to this centre?
Yeah, I would load with the more potent P2Y12, especially if there's the administration of morphine.
And would there be a role for eptifibatide or 2B3A inhibitor in that situation?
Yeah, I mean, as you've alluded to, in the COVID era, we did see higher rates of thrombus and in data here. Just test, please. We did see that patients who were COVID positive did need higher doses of heparin to maintain a therapeutic ACT. I mean, we're not suspicious so far in his case, but if he does have a high thrombus burden, it may be related to late presentation, or it might be due to COVID. So I think a GP2B3A would be very sensible, and I'm sure we will give that as soon as we confirm an occluded coronary. Small test, please.
Earlier to
Should we try an AL
groin.
an AL 0.75, 6 French? Yeah.
Yeah, perfect.
Okay, let's take the run through hypercurt, please. I appreciate we're not giving heparin yet. Let's just wire it and then. Can I have some integralin drawn up, please?
So after wiring this vessel, Dr. Showder, what would be the next step? Balloon or export? Do you know routinely?
Yeah, I
do?
think it really depends what it looks like. Really, I mean, if there looks to be a high thrombus burden, I think we might just use an export, which can be quite effective, and then possibly direct stent. But if there clearly looks to be disease all the way down the vessel, we might want to take a balloon to see if that all goes up.
Can we get an export in the room, please? Yeah, we have. Perfect.
Ready for the first bolus in
Okay, I can take that from you. Perfect. Okay, I can take that from you. Perfect.
Looks like we're 2020 or something, isn't it?
Really odd, isn't it?
Yeah,
Okay,
it
let's give
looks like a cranial view.
So I'm going to give 10,000 to heparin, and we'll give integralin IC, please.
I've got it.
So is there a benefit of IC integralin over IV?
Yeah. Not. I mean, it's not been proven in any randomised study, but there is some data from some of the studies that do suggest you get less MVO on CMR
Okay.
and less microvascular problems with intracoronary. It is an off-license indication,
Yeah.
as in we tend to use it quite. I mean, I use it routinely, to be honest, just to get greater, quicker platelet inhibition.
And would you give both boluses in intracoronary?
To be honest, just the first. Tend to give
Okay.
the first IC and then the second IV.
And do you always give an infusion?
Yeah, typically. At least for 6 hours, just to make sure that
Yeah.
the platelet, as in the P2x12s, had the
Chance
chance
to work.
to work.
Yeah.
So the frequency of use of export's gone down, I would say. Why would you prefer to use export in some cases?
Yeah, I mean, I think in this case he's had 8 hours of ischemia. There's a lot of thrombus. He's got a blocked coronary, and I'd be suspicious that he's going to get no reflow. And this will be difficult with embolisation. So, I think with a large thrombus burden, there is data from the sort of meta-analysis to suggest that an export is beneficial. The only problem is the stroke risk.
Yep.
So I think we just need to mitigate that with trying to engage the guide as well as we can, which admittedly is difficult in this case, but at least having good technique with the export in terms of the way we use it.
Yeah.
He says crossing the lesionals, right? So if we go, take the stylet out, and then we'll go on, and then we'll try and see if we can get some flow.
It can be. No, it
Okay.
can be, but we were just having a chat about guide liner. What's your
Yep.
experience of using guide liner and an export in a 6 French system?
I think I don't think an export. I don't think I'd be able to get an export through a guide liner. I
Yeah.
haven't done it personally, but I suspect they're not compatible.
Yeah.
So that's the device time?
But I personally, based on the guide, I think a guide liner
Yeah, it might be quite useful.
will be very helpful once we've. Well, that's crossed, I think.
Yeah.
It's about a guide liner in the proximal vessel. I think will be a prerequisite for
For getting
my
anything.
comfort for the rest of this case, and probably everyone else's. Yes, please. Should we change the syringe?
Yep.
So if we take this, we'll take this out and then give the integralin, IC, and then see what we've got.
So in terms of device time, I think we've got this in 45 minutes at Bart's. What's your experience in terms of getting patients door to balloon?
Yeah, I mean we aim for an under an hour, which I think is a sort of conservative time. It'd be good to do, you know, our median time's around 40 minutes, 45 minutes. This is probably about average. Obviously the sooner the better. I think we didn't see a significant lengthening during the pandemic, which was surprising. As our door to balloon times are still pretty good despite the need to wear full PPE. Okay, should we take that out? Long flush, please. So we keep that flushing until I'm out, please. So hopefully that will prevent any embolisation to...
And I've got your IC integralin ready when you need it.
Okay, thank you. Okay, stop flushing, export out.
So how do you prevent embolisation with what techniques are you using?
Okay, so there's a big lump of thrombus there. Well, to try and engage the guide as much as I can so that any thrombus is trapped. It at least comes back through the guide, bleeding back profusely afterwards. The flush consistently when you're taking out the export should mean that any clot brought back is exported out the body rather than up rather than to the brain. So I think it's also important to make sure that you don't engage the lesion before aspirating.
Yeah.
And to do multiple small passes rather than just... The temptation is often to just push the export into the lesion and then wonder why you...
Cause distal embolisation, yeah. So we've got flow back now, which is nice.
So that's the first integralin. I mean, to be honest, it'd be nice probably to get a guide liner down and stent.
And would you be thinking about direct stenting or balloon if you... Yeah.
I'd like to direct stent, there's a lot of thrombus.
Yeah.
So based on the thrombus burden here and the TIMI zero flow, based on the data we'd shown, you'd be suspicious of his COVID status, but obviously he's also a late presenter, so 8 hours of chest pain, you tend to get a lot of thrombus, so often quite difficult to piece out, and he's asymptomatic, so hopefully his Abbott ID will be negative. Okay, let's take a picture.
Definitely improvement in flow.
And then should we see if we can get a stent? What do you reckon?
Yeah, what size are you thinking? It's quite a big vessel, isn't it?
I think 438 is what I'd go for, yeah.
Should we get a 4038 stent, please?
Should we put in a reduced antiplatelet stent, please?
And why are you thinking about that type of stent in this particular case?
To be honest, yeah, I mainly deliverability.
Okay,
as in
38.
I'm quite concerned
Deliverability,
about getting kit round this coronary, and the direct stent, I think from personal experience, the stent I've had the most success with has been that stent. So it might be that a standard other stent would
are you
also work.
thinking of stenting back to close to the ostium, proximal vessel?
No, I think we just cover the lesion. I think to be honest, I'm planning to land. There's a bit of plaque just proximally I'd like to cover. And then we'll just see what we've got
just
distally.
At that point. Okay.
I think if we can deploy a large stent and be done, that's great. That's the ideal scenario.
And there is some data from this institute about COVID, etc., anticoagulation, but also thrombus aspiration, 2B38 inhibitor use. Are we finding that we're using these things more during this era?
Yeah, we did mainly during the first wave, didn't we? As in we saw patients who were coming in with asymptomatic COVID infection who had lots of thrombus, stent thromboses, multivessel thrombotic lesions, and we did see more export use and more GB2B3A. And try and stay still, please, sir.
It's difficult to get the stent round because of the thrombus.
Yeah, there's very little.
Yes, thank you.
Yes, please. Thanks. Oh, that's come around nicely.
What did you just do there?
Yeah, so once I had pushback from the from the stent, I advanced the guide cath extension over the stent just to reduce the friction, and then the stent passed. Okay, picture.
Ready?
Yep. Okay, go there for me.
Okay. Going to nominal, which is 11.
Yeah.
Yeah.
Okay. All right, down you come. Okay,
Looks nice.
ready for a picture?
Ready? STEMI 3 flow.
So that's a really nice result now that we've got from that. Do we think we need to post-dilate that?
I would have thought that midsection.
Probably the mid to the
lesion, yeah.
proximal, maybe?
Yeah, I think we give a bit of nitrate. I think the bottom
Yeah.
part of the vessel will grow,
Yeah.
and I think we've probably well sized it. It does look a bit big at the moment, but it'll be better. And I think if we take a 4-5
Yeah.
Yeah.
NC to the
Yeah.
mid and then proximal end, and I think we're
4,
finished.
5, 18 NC, please.
So what happens now in the treatment for this gentleman after his procedure? Now we've had a successful procedure with STEMI 3 flow.
Well, hopefully. Well, I guess the two decisions we've got are about his bystander disease.
Yep.
And then about management of his LV dysfunction, if there is any, and then
Yep.
length of stay.
Yep.
Bystander disease is obviously got the LAD, which needs assessing, and then the OM. I think the OM needs treatment, but
Agreed.
with the LAD also needing an assessment, it might be reasonable for us to stage any intervention to both vessels and do it from the left wrist, because the
And
right wrist is.
And what kind of factors would you consider in terms of doing it as an inpatient or timing of the bystander?
Yeah, it's a good question. To be honest, I think if he's pain-free and stable, I'd be tempted to leave it for an outpatient sitting, as long as we do it within the next couple of weeks. I think I would pressure-wire the LAD and fix the OM.
Is that something you found as feasible in terms of timing?
Yeah, it's difficult because of all the factors yet go there, but it's usually pretty.
14.
You can usually get 16, 18. You can usually get people back within a couple of weeks. Okay, down you come.
You mentioned left ventricular function. So routinely, do you rely on an echocardiogram or an LV-gram after the end of the case?
Yeah, so we routinely do. Yeah, go there. We routinely do LV grams for STEMI unless there's incipient heart failure or concern of thrombus. Yet down you come. Just so that we have a rough idea of how then to match. Especially now, we're not going to get an echo past 6:30. Most centres don't offer 24/7 echo service, and that would make it far easier to manage him to know his LV function. And also, if it's preserved, we probably wouldn't do an inpatient echo.
Yep.
Without murmurs and good LV function, he would have an echo in 6 weeks to gauge his. Yeah, go there for me. To establish his LV function. Ready for picture?
Yep.
Go for it. All right.
Nice.
Very nice.
Should we accept that?
Absolutely.
Okay, REO please. Let's do the LV gram and then look through the left side of pictures. I mean, he's had enough.
Yeah.
Wants to pee.
Very nice.
The tortuosity will mean that anything on the left might not be easy.
Yeah.
And
And it's not just the
LAO
surface,
to
the
finish,
LAD as well, so it's both.
well, that's the thing.
factors.
I'm not gonna pressure the LED and
No,
the OM, so we
no,
might as well
exactly.
just bring him back.
That's it, brilliant.
There you go.
Well done. So the LVDP is 9, which I guess is consistent with reasonable LV function. Okay, so hot flush, hot flush. It's not too bad, is it?
So
So what does that mean for his length of stay?
I think generally we tend to keep people in for 24 to 48 hours if their LV function is either moderate or above. Depending on how well they do, if they've been stable, etc. If they have severely impaired LV function, we tend to keep them in for a bit longer, for longer monitoring.
Yeah.
Maybe 3 to 5 days.
Good for
But I
him,
think for
guess.
this gentleman, he can probably go home at just over 24 hours, 48 hours,
Yeah,
depending on how well he does.
I think as we've tried to get, as you said, we've run a very early discharge pathway here, haven't we, during last year, and he would meet all the criteria to go at 24 hours.
Absolutely.
And we've shown in a large series of people that he would be safe to go at 24, even with his bystander disease if he's asymptomatic.
So sign up. So this gentleman had PCI to the right coronary artery as primary PCI. For 6 hours integralin, for aspirin and ticagrelor for a year. How much contrast he's taken? 165 of contrast. As he's got good LV, take him home in 24 hours. You come back for stage, re-look to the right coronary artery and fresh wire plus mounted PCI to the left system. Thank you. So we just completed a case of a 53-year-old gentleman who presented with 8 hours of central chest pain. His risk factors were he's a smoker, hypertensive, hypercholesterolemia. He did not have diabetes. He came directly to the Bart's Heart Center cath lab, where he had an angiogram which demonstrated a blocked right coronary artery, and he had some bystander disease in the left coronary system. He had one drug-eluting stent deployed in the right coronary artery with Timothy flow at the end of the case. It had preserved LV systolic function at the end.
So I guess it was a nice case to show of a STEMI. I think there were a few aspects that we wanted to discuss. First of all, I guess access and guide. There was some tortuosity there. What was your approach to that, Dr. Jones?
Yeah, I mean, as a centre, and I mean, my default strategy is always going to be a radial approach for any procedure, especially in STEMI, unless the patient's shocked. In his case, a radial approach was obviously our first line. There was a lot of subclavian tortuosity, which did make guide catheter manipulation tricky. I think choosing the correct guide was an AL 0.75 guide fitted nicely and didn't involve as much talking as say a JR4. I mean, we didn't try a JR4 up front because we didn't think it was going to fit, and AR1 didn't work, so an AL 0.75 actually worked, which was relief for both myself and I think the rest of the team.
Yep. No, and I think had it not, I think probably we would have considered changing to a femoral approach at that stage for time.
Yeah, I mean, his femoral access route was clean, ready and prepped, and if we needed to, we would have moved, because obviously it's important to revascularise quickly and not to take too long. But I think our door-to balloon time was around 40 minutes, which is still good considering the technical aspects were difficult.
Yeah, very good. So the approach that we took was upfront export and integralin and then a direct stent, which deviates somewhat from maybe other people's practice as well. I know that our current guidelines say that we shouldn't really be using export routinely on a routine basis. What are the advantages and disadvantages of the approach that we took in this particular case?
Yeah, I mean, you're right, an export catheter is not routinely recommended in guidelines, and it is relatively out of favour. I think personally my practice tends to be to use export catheters in occluded vessels, late presenting infarcts, vessels where there's lots of thrombus around, and I think you can see from the first diagnostic picture that there was a lot of thrombus, and after using the export we can see a big lump of thrombus in the coronary with improvement in the flow to the distal vessels, so I think that justified the use. Personally, I think it will reduce microvascular obstruction and the potential for no reflow, which are both increased in prevalence in people with late presenting infarcts, such as someone with 8 hours of pain. So the plan was to try and prevent potential no reflow. There is that stroke risk, but I think engaging the catheter, the guide catheter, and sort of judicious use of flushing and good practice means that the rates are quite low, and he got away without a stroke, which is always good.
Yeah. So the other aspect of the case, I guess, is that he did have bystander disease. There was some suggestion of at least moderate disease in the LAD and severe disease in the circumflex. What would be our approach now for this gentleman going forward for that bystander disease?
Yeah, the data and guidelines, I think we've got good evidence now to support complete revascularisation. In his left-sided disease, there's that moderate disease in the LAD, and there's the the tight OM. I think we can all agree he needs a stenting, or needs PCR to the OM and needs that treating. The LAD, I think we'd probably pressure wire guide to ensure that we're using physiology appropriately to ensure that we get complete revasc. He's very well, his LV's preserved, as long as we do it within a timely manner, so it doesn't have to be as an inpatient. And now with limited bed bases in the current climate, I think treating him as an outpatient in the next couple of weeks would be the appropriate strategy, unless he runs into difficulty pre-discharge.
Yep. Okay. Good. And you mentioned length of stay, and we did perform an LV-gram at the end of the case. What is your usual practice in terms of deciding on length of stay?
Yeah, I mean, again, everyone's a bit different in length of stay after STEMI. European guidelines are now 48 to 72 hours for low risk. He would meet low risk features. He's got good LV function. He's had successful vascularization. He's got no real comorbidity. Here, we've adopted a very early discharge pathway because of a limited bed base in the pandemic, and he's the sort of person we'd send home at 24 hours. So I'd hope, unless he runs into difficulty within the next 24 hours, that he would be monitored for 12 hours, mobilised, and then discharged at 24 hours, with then a very sort of regimented outpatient pathway with a phone call at 2 days and then follow up at 2 and 8 weeks. And obviously we'll hopefully be seeing him in 2 weeks for his repeat PCR.
Yep. And just final question really is about pharmacotherapy and anticoagulation or antiplatelet therapy going forward for him.
Yeah, our policy's aspirin and ticagrelor following a STEMI for at least a year, and then in certain people you might consider extended DAPT. In his case, if he goes on to have multivessel revascularization, then he'd be a candidate to meet that long-term anticoagulation therapy.
Okay, thank you very much.
Thank you.